دكاترتنا الأفاضل نقدر نبدأ ولا؟
تفضل دكتور إبراهيم، تفضل.
طيب، بسم الله الرحمن الرحيم، الحمد لله والصلاة والسلام على رسول الله. أول شيء أشكركم على الدعوة الكريمة، وأسأل الله سبحانه وتعالى ينفع بما نتناقش فيه، وأن يجعلنا وإياكم دائما مفاتيح للخير للمرضى ولإخواننا في كل مكان. يعني ما أدري، هل تحبوا التوك يكون مخلوط إنجليش وعربيك زي ما يقولوا عربيزي، ولا تحبوا يكون إنجليش، تحبوا يكون عربي، اللي ترتاحوا له؟ لكن المحاضرة كمعلومات وبيانات موجودة على السلايدز كلها باللغة الإنجليزية.
بالعادة محاضراتنا بالإنجليزي حكيم، لأنه في ناس من الباكستان محاضرين معنا.
Okay, then I'll make it in English. Good to know. So I'll be talking about decompressive craniectomy for malignant MCA stroke. As you know, it's a big burden of stroke worldwide, and in our region, it's not any different from the rest of the world. And maybe we are facing this more as the lifestyle and so many things are changing. And also there are many patients, as you know, who are not getting the optimal treatment of thrombolytics and endovascular treatment. So they end up with these. Even those who are having the treatment of endovascular therapy or thrombolytic, they are still prone for this malignant MCA strokes. So let me start with this for the English novelist Kipling and his 6 honest serving men. He said, I keep 6 honest serving men. They taught me all I know or I knew. Their names are what and why and when and how and where and who. And I think these will be the 6 fundamental corners that I will go over in this lecture. So what is decompressive craniectomy, and when it's indicated, who will be really benefiting from it, and how it's done? Is it still controversial to some extent? And where do we go from here? What's the conclusion of this talk and conclusion on decompressive craniectomy in general? So the idea of decompressive craniectomy is not new. It has been there for long time. As you could see there, that some were doing it for religious causes, ritualistic. Skull opening was done by African and Asian, like more than 10,000 years, as per evidence say. The ancient Egyptians, they did
راح صوت دكتور، ما عم اسمع.
the idea of the decompressive craniectomy that we are doing nowadays is back to the early 1900 by Coker. And his statement at that time was saying, as you know, this closed space that the brain is existing in, if there is no CSF pressure, if there is no CSF pressure, but the brain pressure exists, then pressure relief must be achieved by opening the skull, because you don't have so many things to do when the brain is tight and there is no hydrocephalus, less CSF space to deal with. So there is nothing else that you can do. Unfortunately, yes, the medical treatment is there, but it's limited. Despite its sporadic use for trauma and other conditions, decompressive craniectomy was not routinely done till the 1990s. One of the problems that it was associated with poor outcome, because sometimes there is no clear indications, no proper post-operative care. So that had made the progress of the decompressive craniectomy, although it was in the early 1900s, not to grow so fast. So it took almost 90 years to get it really done in practice as routine. And the two main indications for it is traumatic brain injuries and stroke, which is our topic today. So as introducing it as a treatment for cerebral and cerebellar infarcts, that was in 1974, after the CT scan era. People started to talk about surgical decompression. Doing it in a better way, in a more systematic way, started to be in practice more, actually was initially with traumatic brain injury. It got involved in the 1999, and Guru and colleagues, they kind of started to talk about it in the absence of epidural or subdural hematomas. We are talking about just brain edema and brain injury that is causing it. So people started to have this as kind of involvement in the routine practice. The evidence took a few years after that, in the early 200, in the millennium, in the new millennium, to have the strong evidence. And when we talk about the strong evidence, as you know, there are so many things in neuroscience that it has great evidence. However, this procedure had really strong randomized controlled trials, and I'll just go over the top 3 of them. Boring details of numbers and statistics. It's just too important to know that the decimal study, Destiny, and Hamlet, and all of them were done in Europe, as you could see there, in France, Germany, and Netherlands, and they were all in the early 2000s. And basically, they were all targeting the malignant or middle cerebral artery infarctions, and especially the Decimal and Destiny, they were stopped and aborted prematurely because of the significant outcome that was noticed, and the reduction in mortality being seen in the surgical arm. So they stopped it and they published their results. If you look here for combined analysis of the 3 trials, Decimal, Destiny, and Hamlet trials, there is a decrease in mortality by almost 50%. And there was also decrease in the poor functional outcome, because it's something that we don't want to see. So the reduction was significant in the MRS score as well, which means that there are disabled patients who are poorly functioning, but they survived. When it's indicated, this is the main point, because I guess most of the people in neuroscience now, they believe in decompressive craniectomy in a stroke or MCA stroke particular. However, the issue is when it's indicated, when to call for this, and when to consider it. So the recommendations that came out of those trials, that people under the age of 60 benefiting more of this type of surgery. If the MCA infarction volume is more than 145, and the NIHSS score is more than 15, and if the surgery to be performed within 48 hours. So these kind of the recommendation, and we could say that like these were kind of the frame for which cases will be benefiting out of those trials, 3 trials. Then other trials or studies came out as a post hoc analysis, and we will show some of them that are looking to expand the group that may benefit from decompressive craniectomy. But definitely, we all agree that the best people will be benefiting from decompressive craniectomy are those people who are fulfilling this criteria shown on the slide. Other people outside of this outside of this criteria, we recommend, or it's been recommended, that you individualize the treatment as it will be shown here. However, we know that they are prone for poorer outcome when you compare them to this ideal group. This algorithm is being advocated and suggested. %50 of the MCA territory, or the calculation for that is almost 145 cc. If no, then you just continue with your medical management. If yes, then you start aggressive anti-edema therapy, mannitol 3%, whatever the protocol of ICP in your institution. If the patient is already intubated, then aggressive sedation, etc., etc. All the measures that we do for pure ICP treatment. And then you look for the age of the patient. If the patient is less than 60 and the time is less than 48 hours, then you could initiate the discussion about the decompressive craniectomy at this point with the team, get the neurosurgeon involved, and also get the family involved. If the people or the patient is not fitting this, you could just discuss that the expected, or it's expected to have poorer outcome with the family. Let's go back to the people who are indicated, or the group that we are talking about. If the surgeon and patient's family agree on decompressive craniectomy, and what do we mean by this? Because we know that the patients cannot take decision at that point. So it depends on the patient's will, if has been discussed before, what's the family's perspective, and this has to be laid clearly to the family. So if there is an agreement, and I will come to that maybe later on in the discussion, what to expect, and because there will be cultural variability on expectation of the outcome, and also if the patient's will was discussed before and the patient was saying something about being vegetative, or God forbid, the being dependent on others. So this has to be taken in consideration. If the decompressive craniectomy is already done, and we all agreed, and everything is done the proper way, and still there is evidence of herniation, and the ICP, if the surgeon put ICP monitor, the ICP remains high, and still there is ankle herniation, midline shifting, then you have to consider your decompressive craniectomy issues, whether it was done properly or not, and continue the anti-edema therapy. If not, then just continue with your management. Again, can we expand the patients who may benefit from the decompressive craniectomy, meaning that we can do it on people who are more than 60? Can we do it if it's more than 48 hours? Can we do it if the volume is way larger than what we think, and we start to have midline shift, etc., etc.? So, for example, in this slide, it discussed the timing of the surgery, and yet it is not the top or the best evidence. However, the overall conclusion of this study, that there was no difference or major difference, statistical difference in the outcome between people who have done it more than after 48 hours or less than 48 hours. Although in practice, honestly, what we see, so this is a single study, so you could question their results. However, what we see, that the later you go, that we notice that poorer outcome is, and this has been noticed. And again, we are raising this point because this is just a single center study that they looked for this small number of patients, and they are advocating that even if you were late to pick it up, or the family, for example, did not decide early on and they were reluctant, and time passed 48 hours, still consider doing that. How about doing it in older than 60? Because the RCTs made the 60 as a cutoff, expecting that people who are more than 60, because of their physiological status and comorbid diseases, that they may not be benefiting from it. However, they found that the hemicraniectomy increased survival without any severe disability among people who are more than 60 or 61 or elder. So still, this has to be individualized again, because people might be 65 and they are physiologically like 90, and there might be people who are 70 and they are physiologically like people who are 60 or even 50. So that has to be also taken in consideration and play a role in taking the decision. The late decompressive craniectomy, this is again another study that discusses the infarction growth rate and the involvement of the temporal lobe. That's independent predictor for early surgery. So what it means if you are seeing, let's say that's time 0, and at 24 hours there is increase in the IGR, the infarction growth rate, and also there is temporal lobe involvement, then these people are potentially benefiting from the early surgery more than the others, because they are soon prone to herniation. How do we say the people or the MCA are progressing toward the malignant stroke? Because this is what worries us. We see lots of MCA strokes. However, not all of them will be developing malignant stroke that will be herniating. So this is a recent paper that kind of reviewed all the scores, or let's say the top scores that are existing as a predictors of the development of malignant MCA stroke. Some of them are easy, straightforward, like 4 points, and some of them are a little bit complex. So, for example, the MBA score is composed of 6 points, and as you go down, the score is worse. If the patient has less NIHSS score, for example, that takes grade 0. The aspect score, the less is, of course, better. The more the less will be worse. The more is better. The collateral status and the revascularization failure, if the patient had been attempted to endovascular therapy. If it's successful, then they take grade 0. If it failed, then we know that this patient probably will be developing malignant MCA stroke. So as you see here, if the score is 6 versus 0, there is a big area of potential of developing the malignant MCA stroke as you go up. For example, what's the status of DWI, diffusion weighted image aspect? Not on the CT scan here, they put it on the DWI, the involvement of ACA territory, whether it's involved or not, and the M1 susceptibility vessel sign, and the hyperglycemia, and so on. You could review these predictors. However, it just gives you a hint of this patient from the get-go, from the time 0, who might be developing, so you can get the other teams involved, as I mentioned, the neurosurgeon, the intensivist on board. So this patient is potential for malignant MCA stroke. So let's get prepared for decompressive craniectomy from this point. How it's done, and this is probably important for all of us, regardless whether neurologists, neurosurgeons. Yes, the neurosurgeons, they are the ones who are doing it. However, the neurologists as well, they are going to be looking for the scan. They are going to be also involved in the management, so they have to know something about this. So the concept here, the bigger the better. And the craniotomy has to be as large as much as you can, ranging from 12 by 14 to 14 by 14 centimeter. And we have key points has to be addressed no matter what you do with the size. Of course, it has to be big. However, you have to have involvement, for example, of the temporal and reach the squamous bone to the skull base of the middle fossa, and these things I will come to it, or I will discuss it now. So it is frontotemporal-parietal region. It has to be involving all these lobes, reaching the base of the frontal lobe. So you have to see the skull base and being flushed, really, the skull base with your craniotomy flap. Sparing the calvarium 1 centimeter at least from the midline. You could argue that you could go 1 to 2 centimeters, and this is to be or to preserve the bridging veins after you open the dura, because you don't want to get closer. The closer you get to the midline, then the potential of having subdural hematomas from laceration of bridging veins. So keep that in mind, that your craniotomy should be 1 centimeter to 2 centimeter away from the midline. You have to decompress the squamous part of the temporal bone. So again, here, the anterior cranial fossa and middle cranial fossa, you have to have them really flushed with the cranial flap. Why? Because if you don't really decompress the temporal lobe, and the temporal lobe here, if I were to choose between the two, the temporal or frontal, the temporal is more important, because if you don't decompress it well, the patient will continue to have ankle herniation. So no matter how beautiful craniotomy you did, if you didn't decompress the temporal lobe enough, then patient will still have herniation. And that's the reason that some people are still encountering poor outcome. One of the reasons, I'm not saying it's all because of this, but why people are still encountering poor outcome with craniectomies, because it's not done properly. The diameter, as I mentioned, it has to be 12 centimeter or more. The duroplasty, you have to open the dura. It is estimated that if you just took the bone off without removing the dura, that you just released about almost 15% of the ICP. So you didn't do much. So it's kind of useless procedure if you don't really open the dura. The duroplasty or opening the dura in any fashion will add to you another 55% of reduction. So you are talking now about almost 70% reduction of ICP. And we see it. If the patient, for example, had ICP monitor and we took him to the OR, for example, whether it was trauma or whether it's infarction, we see this real time. Like patient is already on like lots of sedation medications and inotropes to reduce the ICP, and ICP is still 25 or 35 or 25 or 26, and then all of a sudden, after you decompress, the ICP will be going down, and you will see that you don't require lots of sedation and lots of inotropes will be stopped. So this is happening almost immediately while you are in the operating room, sometimes before the patient leaves. So this is what I was talking about. So we go extremely big question mark incision, and then elevating the temporalis muscle, making multiple burr holes, because you don't want to struggle with the dura and making lacerations of the brain at this point, because any lacerations, if you just do one burr hole here and one burr hole here and you think that you may get your drill easy, it's not recommended. Do at least 4 or 5 burr holes, so that will make the connection between them easier, and then elevate the bone flap, coagulate the dural fissils. And the most used fashion of the dural opening is the star way of opening it. And that you could, if you have dural graft, if you have pericranium, for example, you can put it on top of the dura. You could just lay it on top, or you can add just a suture. However, don't suture it tight, otherwise you didn't do the goal of the surgery. The whole goal of artificial dura or pericranium or any other substance is to isolate the brain from getting stuck later on when you do the cranioplasty to the skin, so that will make your job when you do the cranioplasty easier without injuring the brain tissues. So this what you may see, although this might not look the ideal. However, if you were to look here, that the surgery is all the way to the squamous part down here. And if you were to look here, you could see the clinoids even on the bone image, which means that the surgery went all the way to address the temporal lobe. Why it is still controversial, why we are still discussing it, and some people, which I think are getting less in the neuroscience side from both neurosurgeons and neurologists. We still face them every then and while, but I think the evidence is piling up and less people are against it nowadays. However, one of the problems is the lack of awareness. And when I say lack of awareness, I'm not talking about public, because public, they don't know what surgery, what intervention that you are doing and what medications you are giving. I'm talking about physicians. We still have our colleagues, for example, in ER or ICU or whatever specialties that are involved. They have to be aware of this procedure, and they have to know more about it, so they can also advocate for it and seek help when they are getting such cases, without a delay, just saying this patient has established a stroke, nothing to be added, and then it's not a priority. Also the guidelines, I agree, maybe it's too much to review every then and while, like you find 80 pages of evidence to look to read. However, I think to some extent it's now more clear for the stroke guidelines that the decompressive craniectomy is well advocated. The other problem is that the other side of the middle cerebral artery strokes, when people say, oh, we have seen patients who survived without surgery, but in reality, how many they are? Like when people are reaching, we know that the mortality is extremely high, and we can't judge by X or Y who really survived malignant stroke. So that's also to be taken in consideration. One of the challenges of the decompressive craniectomy is the care and the burden after decompressive craniectomy, because there are consequences or complications that may be raised from the decompressive craniectomy, and I will try to address some of them shortly. This is an example of local study that was run by our colleagues here in Saudi to address their knowledge about the decompressive craniectomy, and the study concluded that they in between the surgeologist and intensivist about that. The guidelines are getting updated every then and while. And as far as I know, the latest were the 2019, and I think soon there will be a release of new version of the guidelines. And if you look that there are changes that we have already discussed, and the level is getting better to some extent. We are getting level A evidence of decompressive craniectomy. However, there are still talks about the elderly people who may still benefit or not. So we have to get ourselves familiar with going over these recommendations every then and while. But for the time being, I guess what I introduced as a criteria might be covering most of these aspects. One of the problems that we face with middle cerebral artery infarctions is the hemorrhagic infarctions. And we know that these people may really, or like they tend to have a great mortality. So this is something really that we have to keep it in mind. And sometimes it is really making surgeons refrain from surgery, because when they see these kind of scans, they really get reluctant sometimes, because they expect really poor outcome after such changes. The consequences or the complications that might be raised or that might be faced, actually, the subdural hygromas, collection of the CSF under the dura, under the bone flap, or under the skin, that may require tapping, may require surgery, might be a potential for herniation later on, because the CSF starts to push again on the brain. So you have to deal with this. The potential seizures after surgery, although this is when you talk about strokeectomy, if the people are taking brain, which is very less advocated. And I'm saying at personal level, I'm not practicing a strokeectomy, meaning that I'm not removing any brain tissues. And I think if the patient is getting to that stage, I think the benefit might not be the best. So I'm advocating the decompressive craniectomy, duroplasty, but not that much advocating strokeectomy, although there is there are a few studies that are considering that it may benefit the patient and reduce the mortality. The late onset hydrocephalus, because as we know that after stroke, after surgery, potentially the CSF absorption or CSF dynamics might be changing. So these patients are prone, regardless, to hydrocephalus. The bleeding, and we have seen it in some patients, if it's not, if the hemostasis is not achieved well during the surgery, or if the patient sometimes being on dual antiplatelet stroke, and despite that he had or she had a stroke, this will make them more prone to have, for example, epidurals after surgery, subgaleal hematomas, and that might push the surgeon to take them back again for surgery. This is one of the burdens. And also infection of the wound or bone flap. And by the way, for the bone flap, even the physicians, they sometimes question, where is the bone? Where did you take it? So we have three things that we can do with the bone as surgeon. We could put it in the abdomen, as you all know, just subcutaneous tissues, and put it back after like a period of roughly 6 to 8 weeks. And the concept here is when the brain is relaxed and sagging enough, where there is no pressure is expected on the bone flap, then, or on the brain, sorry, you can put your bone flap back. Sometimes we put it in bone bank, which is basically fridge. That's -4 degrees. If it's available in the OR, then fine. If not, then you can throw the bone flap and do cranioplasty later on with titanium mesh or acrylic or any other alternatives. The strokeectomy that I told you about, there are publications about it, that if the patient had decompressive craniectomy and still patient is showing signs of herniation and further infarctions, then you consider the strokeectomy, removal of the brain tissues in the second surgery. And my point here, if there is enough, or the decompressive craniectomy is done properly and good size and centered around the stroke, I wouldn't consider taking the patient back. That's a personal practice, because taking patient for another major surgery of a strokeectomy, then you are increasing basically the risk of morbidity and mortality. However, if the question, I guess, here, and the criticism here will be, if the decompressive craniectomy was not done properly from the get-go, and then you are seeing further cerebral infarction, then I guess the problem is the previous surgery or the initial surgery, not that the patient was in a need of strokeectomy. So what's the conclusion now? The conclusion in regards the surgeons, decompressive craniectomy of malignant middle cerebral artery stroke. I'm sorry, I'm keep saying middle meningeal artery because I love this embolization of middle meningeal artery for subdural hematomas, for chronic subdural, because being endovascular, I love doing it in some patients. So that's why it's getting on my tongue more than the malignant middle cerebral artery. So the decompression for middle meningeal artery or malignant middle cerebral artery strokes is there to stay. So it's a procedure that we have to admit it's there. We cannot say it is rubbish, it is blah, 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 it's no evidence. No, we cannot argue this anymore. So the other message to the surgeon is go big or go home. Either you do it properly or don't do it. If you just do the tiny, small 5 centimeter, and I have seen it, honestly, going like 5 centimeter diameter bone flap and calling it decompressive craniectomy, it is not by any means. Call it craniotomy, call it anything else, but don't call it decompressive craniectomy. The indications has to be tailored, and although we all advocate the right thing for our patient, but we could argue sometimes that patients may or may not benefit. However, get the family involved, be as a team in taking decisions, not just dump it on the neurosurgeon and say, here's what I'm waiting from you, just get back to me whether you are going to do it or not. I think neurologists, neurosurgeons, and intensivists has to discuss. The neurologist, I think they have to identify the key things that I discussed. For example, in the risk factors that predict the malignant middle cerebral artery stroke from the beginning, and get the neurosurgeons and intensivists involved early on, not when things go south really bad. Then you get them involved when the patient already had right pupil dilated or both pupils are dilated, and then getting them involved. I don't think that's the right time to get involved. Second opinion is also valid for everybody, not just neurologists, for neurosurgeons and neurologists. Yesterday, me and one of my colleagues, we were talking for maybe 10-15 minutes on a patient, discussing whether we think the decompressive craniectomy might benefit that patient. And we both agreed. But sometimes you need the second opinion to push you further when you are reluctant about certain points. To the intensivist, we rely on them much in the neurocritical management and in guiding the ICP treatment. And it has to be done and guided properly, the follow-up of the electrolytes and the osmolarity, and seeing when the patient is developing, when to stop the ICP treatment if the patient is developing consequences of the hyperosmolar therapy, etc., etc. One of the things that is always a challenge is the repeated scan of the patient, which is big challenge in any hospital where, excuse me, no matter where you go. However, I guess the problem of transport to the CT, because neuro, we have nothing other than imaging sometimes. Yes, the clinical might be compromised by sedation and ventilation. So we need imaging. And the idea of portable CT, I think if money were to be invested in that, that will be great, because you don't need to fiddle with having 2 or 3 nurses to transfer the patient, the respiratory therapist, and the ICU doctor or neurology or neurosurgeon to escort the patient down. You could just push it on its wheels and get a good idea, because you are not looking for fine details. You are just looking for basically herniation and whether the patient is deteriorating or not from the imaging point of view. This is all what I have to say. And I'd like to thank you again for inviting me to this gathering, and also invite my colleagues, Dr. Ahmed and Dr. Hussam, who helped putting this talk together. With no further things that I may add, I'll just go to the discussion. تفضل دكتور أحمد.
Thank you very much, Dr. Ibrahim. It was the gold information about the craniectomy, because it's a problem between us, neurologist and neurosurgeon, about guidelines, outcomes. It was very helpful for us. Thank you very much.
Thank you. يعطيكم العافية. You are welcome. You are welcome, Doctor. Any comments from? And I'd like to hear from you guys. One thing I may say here, by the way, sometimes if no proper, like this has to be really clear, you have to calibrate and titrate what we have discussed based on the institution that you are working in. Sometimes the patients are paying from their own money sometimes for care. And sometimes you may do a surgery and you may not have, in certain situation, good access for imaging on the right time. So I'm always saying, like, because of what you commented on, because it's an argument always between the neurologists and neurosurgeons, sometimes the facility may not allow such things. So you have to calibrate this based on the place where you are working, and if all these things are there, then it is the way to go and to do it. So please take the talk that to be practiced in resource with, I shouldn't say excellent resources, but I would say with moderate resources to get what you want.
Dr. Ibrahim, Dr. Ziad asked if how about occipital decompressive craniectomy for large cerebellar infarcts? Any specific criteria or age difference about MCA, large malignancy, stroke?
For the suboccipital decompressive craniectomy, it's actually way much easier because the evidence is strong, and if you don't decompress them, then we know that what will happen. The question is sometimes that before we consider the suboccipital decompression, if there is hydrocephalus, we always address the hydrocephalus first. But the suboccipital craniectomy is even expected to have a better outcome, especially if it's only cerebellar with no brainstem infarction. Their outcome is way better. So whenever there is a change in the level of consciousness, we always consider it without any discussion. And
Dr.
the same
Ibrahim,
concept applies. وياك حبيبي. وياك حبيبي.
جزاك الله خير دكتور إبراهيم.
وياك.
Excellent speech, barakallah feek. I have a comment. Do you know, this is kind of a very important subject with the suboccipital crani and hemicrani for malignant MCA stroke and all those things. Do you think virtual workshop can be offered to our neurosurgeons?
Well, I think
how to do hemicrani?
Workshop, if you mean cadaveric workshop, that's if you mean cadaveric workshop, Dr. Maher. If there is a lab, yes, definitely it can be demonstrated on cadaveric workshop. That's even much better for the neurosurgeons to have hands-on. It just has to be a good lab where they have the facility. For example, here in Saudi, alhamdulillah, now we have 2 labs that do have the cadaveric facility, where people can, although in the past, like 10 years ago, we all used to travel to Europe or North America to get these courses. So definitely, if there is any cadaveric lab, it can be demonstrated, and it's a good thing to see. Yes.
Okay. So Dr. Ahmed, I think we need to discuss that, Dr. Ibrahim, how to do that workshop for our neurosurgeons. الله يجزيك الخير. I think
وإياكم يعطيكم العافية وشاكر لكم والله. I'm so thankful introducing me to this group. وبإذن الله سبحانه وتعالى اللقاءات القادمة أفضل وأجمل، وإن شاء الله نراكم جميعا في خير.
حياك الله أبو الزبير، حياك الله. الله يجزيك الخير يا رب.
الله يحفظكم. يا من الله. السلام عليكم.
السلام عليكم.